The ill-appearing child. The child that seems okay but has unexplained symptoms. The child who has no complaint but arrives with a scribbled piece of paper that says, Diagnosis: Anemia. We see a whole spectrum of patients who just don't have enough boxcars on the oxygen railroad. How do we deal with anemia in the PZD so that we can do the right thing at the right time?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Anemia is a sneaky thing because it's not a disease in itself, but the marker of some disease, which to us means two things. One, anemia is just the beginning of the puzzle, which may or may not have anything to do with the patient's chief complaint. And two, we are often the ones tasked to do something about it, which may mean workup and treatment, or may mean sending the patient back from whence he came. So many variables, and like any disease process we see, the trajectory we place our patients on makes a big difference in the outcome. We need an approach to anemia. Maybe not a comprehensive diagnostic algorithm, really not for us in the emergency department, but we do need to jump over those pitfalls and land on a solid plan. So, we'll keep it simple. Let's talk about the major questions we need to ask ourselves, and we'll practice this approach with a few cases. First, a caveat. Be sure to use a pediatric reference when interpreting lab values. The definition of anemia, the lower limit of normal, will change with age. For example, up to 2 years of age, 11 grams per deciliter is the lower limit, but kindergartners and preschoolers are allowed to go down to 11.5 grams per deciliter, while school-age children have a lower limit of 12 grams per deciliter. MCV has its own limit, so just do yourself a favor. Don't rely on your labs turning into a red value. Take a look at the trusted reference and double-check before you label a child anemic. Okay, now for our approach. There are 4 main questions to ask when faced with anemia. Onset, slow or fast. Red blood cells, small or not. Production of red blood cells, increased or decreased. And finally, what do the RBCs look like? Let's go through each. First, was the onset of anemia slow or fast? Patients may have a color change that initially was unnoticed, but later a grandparent comes to visit, or someone who may not have seen the child daily says, he looks a little pale. Parents may complain of a slow, progressive loss of appetite or energy level. Oftentimes with slow onset anemia, cardiac function is fine. The child may actually be asymptomatic. Remember, the mantra of children is play or die. They often go right about their business with slow onset anemia. That brings us to symptomatology. In adults, we see anemia in the ED all the time. And what's our first question? Well, is the patient symptomatic? No, it's true, and this will often drive our management. But in children, this is probably not the best strategy because if you ask the parent, of course the child is symptomatic. Of course he doesn't eat enough. Of course he looks pale. There are many cultural factors at play, and many traditional cultures still operate on the 4 humors model. You know, melancholic, phlegmatic, sanguine, and choleric. It's true, but I digress. The point is, do your best to ask in non-leading ways. The question to yourself is how quick the onset is, but you get the answer by asking a series of functional, practical, and contextual questions of your parents and your children what specifically did they notice and when? Acute onset. Oh, now do I have your attention? By the way, as you'll see, sometimes the patients with slow onset anemia are actually sicker. But fine. Acute onset, here we go. In this case, of course, we think about hemorrhage, but really that's a different topic. I know that you know when someone has trauma, when they're hemorrhaging. We're talking about an acute anemia, so an occult etiology. And that acute onset may not actually be that traumatic or dramatic or really linked to any particular event that anyone can suss out on initial presentation. Maybe there is bleeding from the lower gut or hematemesis. That should be pretty straightforward, but you may just see vague symptoms, vague complaints, and a little jaundice on exam. Or you're feeling for the abdominal exam, and is that spleen large? By the way, what's the easiest way to miss splenomegaly? Well, not feeling for it. What's the best way to feel for a large spleen? Start in the right lower quadrant. Yep, all the way down there. Make your way up slowly to the left upper quadrant. If you start by mashing where you think the big spleen should be, you'll just hit, well, big spleen and not really feel its contour and think that's just part of the abdomen. Work your way up with a cupped hand, gently, distract the child, talk to him, interact with him, until you can feel the tip of the spleen. And hopefully that is safely in the left upper quadrant, tucked under the rib cage. But you may surprise yourself. Acute onset anemia, we're talking days sometimes here, can also present as a sudden pallor or even high output heart failure. Okay, we got onset down. The second question to yourself is, what is the red blood cell size? Is it small or not? A small size, or small mean corpuscular volume, is one of two things. Either a decrease in heme or a decrease in globulin. Really. A decrease in heme could be from low iron stores or anemia of chronic disease. So the chronic inflammatory process makes it difficult to make the heme. A decrease in globulin is pretty simple. You got thalassemia. Okay, so low MCV is only a few things. And honestly, for our purposes, it's mostly iron deficiency. Anemia with a low MCV in an otherwise well child? Whew, that was easy. So, what about a normal or high MCV? Well, that's a red flag. It can be pretty much everything else. This could be a cell membrane defect or even an enzyme defect, an immunologic disorder, or a non-thalassemia hemoglobinopathy, bone marrow failure, chronic blood loss, maybe from a Meckel's diverticulum, or inflammatory bowel disease, or even megaloblastic anemia, and the differential keeps going. The thing that we just need to hold on to is that this is why we send that slew of labs to help the inpatient team or the primary care provider later on to eventually get to the answer in the stable child. Give me a good old low MCV anemia, maybe a toddler who drinks way too much cow's milk, any day. All right, onset, chronic or acute. RBC size, small or not. The next question, RBC production. Is it increased or decreased? How do we tell? The reticulocyte count. Basically, whatever is going on with you, you would rather have an increased reticulocyte count. Why? Reticulocytes are immature RBCs. The more you have, the more you're producing, and good for you. If you have anemia and you have a low retic count, then not so great. That's basically all we need to know. But if you came here to get your nerd on, or pass your PEDS board exam, or just want to get to the boss level, here's a little bit more. An anemic patient with a decreased reticulocyte count may have a congenital anemia, like Diamond-Blackfan syndrome. The typical patient here is an infant or toddler with a normal or high MCV, but he has low reticulocyte count. Normal platelets, a normal WBC. This is a pure erythroid aplasia, another name for this. Just the RBCs are affected, it's pure erythroid aplasia. Now this is in contrast to Fanconi anemia, where all cell lines are affected. Of course, both of these are diagnoses of exclusion, not one we would make in the ED, but it's important to know that even the most well-appearing toddler needs follow-up. The acquired version of pure erythroid aplasia is transient erythroblastopenia of childhood, which can be caused by an autoimmune disease or a viral infection. Said another way, an increased reticulocyte count? Awesome. It means that whether you're losing due to destruction or quick turnover, you're still making it. The body is trying to compensate. The classic case here is when we see a patient with sickle cell disease. We see that he's anemic, and his reticulocyte count is up. We feel relieved. His body is already on it. It's doing its best to recover. If his reticulocyte count is normal, or worse, it's down, that means destruction junction, bone marrow, you lost your function. Then we worry about an aplastic crisis. So, onset, RBC size, RBC production, and now cell morphology. Now, if you get this far, it's time to just look all that stuff up. There is a separate differential diagnosis for each of the various morphologies, and it's not something that's useful at the bedside. Plus, there's only so much brain real estate to go around. Okay to look up. Sarah is a 20-month-old girl. She's healthy. She's here because she's been fussy, not eating over the past week. They called their pediatrician, who couldn't see the child, so what were they told? Go to the ER. The child arrives and looks relatively well, and you're really getting sort of this vague, bland story at triage when you're looking at her vitals and you see that her pulse ox is normal, but it's picking up a heart rate of 150 beats per minute. Luckily, Sarah is pretty calm, but it just doesn't match. You listen to her lungs, you gently feel her pulse so that she doesn't start crying, and yep, it is 150. She does look pretty pale now that you look at her. Now, the family in general is pale, but she wins the pallor contest. Her abdominal exam is normal. Now, really, you probably would not have done anything else in the ED based on her chief complaint, her history, and her exam, but unexplained tachycardia we have to look into. Unexplained tachycardia and pallor, we definitely want to take a look into this. So, what do you do? How do you start, and what would you order? Well, you could do a point-of-care hemoglobin, just a finger stick, but you really already know she's anemic, and you don't have much else information here. So, you know what? In for a penny, in for a pound. Her hemoglobin on official laboratory analysis is 4 grams per deciliter. Well, not normal for anybody. Her MCV is low at 60. Her reticulocyte count is 1%. So let's work through our questions. Slow or acute onset? This appears to be slow onset. It's been going on for quite some time. There's no way that she could have gone to a hemoglobin of 4 grams per deciliter and be awake and interactive and relatively well appearing if this were an acute process. Okay, there's some subacute slow onset process happening right now. Do we think this is a problem with production or destruction? Well, she does have a slow onset. Her reticulocyte count is low. Her body is just not compensating. So let's say this is a problem with production. Her RBC size is low. If we were to look at a blood smear, and of course we don't have that available in the emergency department pretty much ever, but if we were, we would see some variation in shape in the RBCs. A few are what are called cigar forms that are pretty suggestive of iron deficiency anemia. Now, that may be just enough for us in the ED, but this girl needs some treatment. We have to decide, does she need blood? Does she need iron? Does she need both? And before we go mucking up the rest of her anemia studies, we should probably draw some more labs. Let's just say that they all became available to you right now, just for the sake of discussion. Let's just say her ferritin is 4 micrograms per liter, very low. And her total iron binding capacity, her TIBC, is high, 450 micrograms per deciliter. Her serum iron is low, 10 micrograms per deciliter. Now you may say, let's just give her blood. Forget it, move on. But remember, the tempo of intervention in the emergency department really should match the tempo of the disease. Now, this is a good excuse for us to ask ourselves, which of these studies, when the ones we order usually for the inpatient team and we forget about, we don't follow up or look for, which of these are first affected in iron deficiency anemia? Well, the first to go is your ferritin. If you don't take in enough iron, then your iron store in the form of ferritin gets dipped into first. In fact, your ferritin is like your anemia gatekeeper. It is usually totally exhausted before any of the other studies are affected. Once your first defense of ferritin, your ferritin fence, if you will, is breached, then your body says, we need to raise some funds for some repairs here. Let's open up a line of iron credit from the TIBC bank. Your total iron binding capacity will go up. It's doing everything it can to hold on to more iron. Okay, now your credit is maxed out, and so your serum iron starts to get affected. Your special savings is now gone. Then you get some repossession of assets. Finally, your hemoglobin takes a hit. And only then, when you are evicted from your hemoglobin apartment, will you have to downsize. Your MCV is affected. So it goes ferritin first, then TIBC is affected, then serum iron, then hemoglobin, and then finally MCV. Your body is doing everything it can to do damage control in a stepwise fashion. What was going on with Sarah? Well, pretty much an exclusive diet of meatless chicken nuggets and French fries. Johnny is a 4-year-old boy with 1 day of fatigue, decreased PO intake, and decreased urine. Overnight, he began to look pale. When his voiding urine in the morning was dark, his parents bring him into the ED. He looks ill. He's barely interactive with you. There's no fever. His pulse is 168. His blood pressure is 74/42. On exam, you see what the parents mean by pale, but you also see that he has some scleral icterus. His spleen is large. His point-of-care hemoglobin is 2.5 grams per deciliter. Thoughts so far? We can almost get to the diagnosis from this alone, but let's go through our approach. Onset, this is acute. A production or destruction problem. It looks like destruction with acute pallor and jaundice. RBC size? His MCV is 90, which is okay for him. Remember, we want to know small or not. His reticulocytes are increased at 22%. If you happen to have a smear, it would show spherocytes. So our questions: onset, size, production, morphology, acute onset, normal size RBCs, retics are buzzing, so increase production to compensate for this destructive cause, and Morphology is abnormal. That and a large spleen. He has hemolytic anemia. This can be due to an enzyme deficiency that has been stressed with a drug or an autoimmune disorder. About half of cases of autoimmune hemolytic anemia are idiopathic. The other half are secondary to a list of things like lupus or psoriatic arthritis or IBD or others. Other secondary causes are due to viruses like Epstein-Barr or Mycoplasma or HIV, to name a few. On further questioning, Johnny had what his mother called walking pneumonia a few weeks ago. So, you see this ill, tachycardic child with a hemoglobin of 2.7. What do? Transfuse, right? Throw in some units. Well, not so fast. He does need support, but remember what's happening here. The antibody that has been generated has attached to the red blood cell membrane, altering it. Every time that RBC circulates past the spleen, it won't pass inspection and it runs the risk of getting sequestered and destroyed. Do we want to add fuel to this fire? Well, sometimes you gotta. But we also need to blunt the pathophysiologic response. This is why we may give steroids or IVIG to these patients to blunt the autoimmune response. It doesn't mean we can't give blood, and if this patient were an extremis, you give what you need to give to support hemodynamics. In this case, you can get the treatment first to cool things off, and then give blood, just slowly and with frequent checks like every hour to be sure that we're striking the right balance. This is not something that we're going to primarily manage in the emergency department. This is when you do really want to get your consultants on board or transfer to a facility that can do this. The important thing, though, here is to think things through. Part of that is realizing that Johnny ain't going home like this, and you aren't going to be taking care of him in-house. If you have a hematologist available, this is the time to call. Hemolytic anemia is no fun for anyone. If you have to transfer, stabilize, and go for it. This is just the beginning of Johnny's long road ahead. After a few days in the hospital, Johnny is much better, and the other labs that you sent before transfusion ended up resulting. You follow up and you see that he's Coombs positive. He has an antiglobulin that's positive, and his antibody screen was positive. He got his treatment, and you started the diagnosis train running by sending those labs. Now we're starting to get the feeling that the point of today's talk is not to get to the exact answer. It's not important that we were right from the beginning. It's important to think through the potentially dangerous causes and choose the right treatment at the right time. There's a whole world of hematology out there that we may not even scratch the surface of, but we can do our part. Milo is a 7-year-old boy with 1 month of fatigue. Let's just call a timeout here. Do you see the pattern? It's in our nature to start to downplay or dismiss symptoms that have been going on for more than, a few days. This can't be emergent, right? And believe me, I'm with you. It's hard to suspend belief enough to get through this. And whatever the non-urgent component is, it may or may not be related to what brought them in. It's just hard. As long as we know what's going on with us, it's fine. All right, let's get back to Milo. He's tired, and it's been a while. Not much new. Got it. Well, what's that? A fever for a day? Okay, you and half the waiting room. Bruising for a few days? Okay, he's an active boy. But you're listening to this list of complaints, and it starts to kind of fall together. You start to put it together and see past and notice that this boy is all of those things, and he looks unwell. He also looks pretty annoyed and uncomfortable. He's febrile. He's pale. You get him in a gown and see that he has petechiae on his chest. What are you thinking now? Temperature is 38.7, pulse 96, respiratory rate 20, Blood pressure, 98/60. In general, he's tired. The rest of his exam just shows no organomegaly. His hemoglobin is 4 grams per deciliter. Okay, that goes with anemia. Not a huge surprise here. His MCV is 98, so up. That opens up our differential. His reticulocyte count is only 0.2. Very much down. What does he have? Okay, not a fair question yet. His WBC count is 2.5. Also down, and thinking, well, this could be viral suppression, but now that's 2 cell lines down. Then there's the platelet level of 7,000. Ouch. All cell lines down. And febrile. Now, there's a long list of things that can cause what he has. He has some type of crisis. A crisis where 2 or more cell lines are affected. Blood cells come from marrow, so it's an aplastic crisis. Sometimes I like to reverse engineer how we could really mess things up when we see a patient. Let's paint a picture in which this could have been completely missed. Milo comes into triage, it's busy. Chief complaint, fever, like everyone else. He's tired. There are a lot of subacute complaints, and maybe the family appears a little high maintenance. You do a quick, I'm shopping in a fancy store exam. You look, but you don't touch. You don't really notice his pallor. He's kind of bundled up. He seems a little surly. So you direct the little time you spend in the room to the anxious mother. You never notice his petechiae. Petechiae that would be especially important in the context of his pallor, in the context of these ongoing complaints, in the context of his fever. It's not normal for an otherwise healthy 7-year-old boy to suddenly stop playing at school and go home and need extra blankets on the sofa and not want to eat or do anything and bruise himself easily when he brushed up against the coffee table. You know this because you asked. You see what I mean? We're in a minefield. I'm not advocating bloods on everyone with vague complaints. I'm just saying be present and use all of your clinical bedside tools. Your eyes, your ears, your hands, and be selective. The blood count saved us here. The paradigm we always think of is a patient with sickle cell disease and parvovirus when we think about aplastic crisis. But this can be from a variety of drugs. The biggest culprit nowadays is anti-epileptics, but toxic exposures like to benzene or even chemotherapy and radiation, all of those things can precipitate the bone marrow failure. Also, all of the viruses we mentioned before about autoimmune hemolytic anemia can be involved, and we can add to that list all of the hepatitides. So you see Milo, and you hope that this is the case. You hope that it's due to potentially some virus that just needs some supportive care. Well, what do? Well, here we have a febrile, neutropenic patient without cause and other cell lines down. We have to treat the worst first. We stabilize, we give empiric antibiotics with cultures, and we order a blood smear. It comes back as a panic result. Blasts. Milo has leukemia, presenting as pallor, fatigue, and eventually, with petechiae and on laboratory analysis, an aplastic crisis. Martin is a 16-month-old with 3 days of coughing, maybe some congestion, and 1 day of what the mother describes as looking pale and not really peeing very much. When his mother noticed a darker color to his urine, she became concerned and brought him in. On arrival, Martin has an increased work of breathing. He's pale. He's tired. When you listen to his chest, you hear crackles on both lung fields. Your snap judgment may say, well, all this looks like bronchiolitis. Maybe some dehydration that's related. And, in the right season, it may fit all too well. But you do a full exam, especially on this child who appears ill to you. He has trace pitting edema to his sacrum. His liver is enlarged. This isn't bronchiolitis. This is congestive heart failure. Well, from what? Well, it could be myocarditis, maybe a terrible primary respiratory cause, but the pallor and the dark urine? You investigate. Hemoglobin is 8. Okay. WBC's 34,000. Not expecting that. You look at the differential. The lab's internal controls prompted them to do a manual count. Segmented forms are 53%, lymphocytes are 33%, and looky here, he has some nucleated RBCs at 11%. So, effectively, the WBC count is 34 minus 11, so 23 suddenly seems a lot better somehow. You remember that your trusted buddy and coach mentioned that nucleated RBCs look a lot like white blood cells, and the automated cytometers may not distinguish between them. The big question here is, why are there so many immature, not ready for prime time red blood cells in circulation? Let's look at the rest of the CBC. The MCV is 88, so not terrible. The platelets are okay at 44,000. The retics are fine at 9%. So let's work through our approach. Onset, fast. RBC production or destruction, destruction. MCV, normal. This leaves us with a differential that it's not huge. It has to be some type of autoimmune anemia or enzyme deficiency. Nothing really pointed to an autoimmune cause in Martin's case. So what enzyme deficiency could cause this? We need a little more info. When you ask, mother remembers that they were told at some point that Milo may have a sickle cell trait. The family is African American. I wonder. Mom, has Milo ever been tested for G6pd? Does that sound familiar? No, doesn't sound familiar. Okay, you go through the long list of what could precipitate a G6pd event, just in case. Remember, we're just trying to hypothesize here. It turns out, last week, he had a little cough, and a very well-meaning auntie suggested that he take some of her trimethoprim sulfa. She still had some Bactrim left over from a urinary tract infection last year. They crushed up about half an adult dose and mixed it into his pudding over the past day. Now, G6pd deficiency is an interesting thing. There are a few variants, one of which, the African variant, is milder, and people can live with it, not know about it, and until or unless they eat, say, fava beans or take a drug that could precipitate an enzyme crisis, they may never know. What do? Stop the offending drug, closely monitor him, and be careful with supportive care for this child who has some mild CHF. Goldie is a 12-month-old girl who is brought in for poor feeding. Worse, especially over the past 2 to 3 days. Now, she hasn't been feeding very well for at least a month, maybe more. So you ask, well, what does she eat? Well, mother is a bit upset that you asked. She proudly states that her daughter is only breastfed. Okay, that's cool. No bottles, that's good. But no other foods, no solids? No, the mother reports. She thinks that Goldie is not ready for anything else. It turns out there is a little bit of a cycle here. On previous notes, she had stopped progressing with her milestones at about 9 months of age. Goldie is consistently below the 5th percentile in weight and the 10th percentile in length. The family had just been referred to Failure to Thrive Clinic, but The mother is waiting to speak with her herbologist friend to see if that's a good idea and if there's maybe a natural alternative. Well, you're getting the very, very natural vibe here from Mom. She is very defensive and honestly probably worried that we are going to judge her. But there also is a little bit of a chip on the shoulder here. You try to show her you're on her side by asking about her health. Well, she loves that. She regales you with her radically natural lifestyle. Among all of the tips she dishes out to you, you quickly find out that the mother eats no animal products. She also refuses to take any supplements other than what her friend recommends. Aha. You may have the answer to Goldie's problem. You convince the mother that testing Goldie's blood today is a good idea. Her hemoglobin is 8.2. MCV, 117. Platelets, 500,000. Retics are 4%. So, our approach. Onset is slow. RBC production or destruction problem? Production problem. MCV, large. If you were to see a smear, you would find large RBCs and some hypersegmented polys. This is megaloblastic anemia, probably from B12 deficiency. Now, a PRN dose of Taco Tuesday would help, but this is a no-go in that case. Seriously, though, this will take some hardcore counseling and ongoing rapport. We really need to keep them as an ally on our side. Also, it's important not to get too stuck on labels. Plenty of vegans supplement their diet, and plenty of omnivores are nutritionally deficient. It helps to do a little digging, don't assume, and ask probing questions. So you do make some headway. You get Mother to consider supplementing herself with vitamins in the meantime while she is exclusively breastfeeding. Sometimes the war is won after many small battles. You leave a message with her primary care doctor and suggest closer follow-up and a consultation with a nutritionist. Sammy is a 19-month-old boy who was brought in by his mother for 2 weeks of being really tired, and she thinks he's pale. On exam, he's both of those things. His heart rate is 144, respiratory rate 26. His exam is otherwise unremarkable. Hemoglobin is very low at 3.6. MCV, okay, at 88. Reticulocyte count, it's a whopping 0%. WBCs are okay at 8,000. So let's see. An otherwise and previously healthy toddler with slow onset anemia, it's a production problem and a normal MCV. There's only one cell line affected. It's not due to iron deficiency. The differential here, luckily, is narrow. Do you remember that crazy diagnosis we talked about earlier? The one when I said it, you almost rolled your eyes? You know I can tell. Anyway, it's the one that is either acquired or congenital. The congenital is Diamond-Blackfan anemia. The acquired form can be caused by a bunch of things, but mostly benign viruses. It's transient erythroblastopenia of childhood. Luckily, this will get better no matter what you do. Now, you'll need follow-up. Who knows what the twists and turns will end up being and what will happen with this patient's course after he sees us. And again, this really isn't our diagnosis to make. It's just important to know whether you need to hold on to this child or not. And also, you may wow everyone with your studly knowledge. The question again is, what do I do now? How much do I work up or treat? Do I give blood? I mean, he's symptomatic, but this will improve regardless. I think the problem is that here we don't know the trajectory of these non-crashing patients. You do want to be careful and not give blood if the risk to benefit ratio is high, but who is to say this child is not on his way to a lower hemoglobin? If you were to give blood here, how much would you give? Remember, we're not talking about the crashing patient. we're not talking about the hemorrhaging patient. We're just talking about the symptomatic anemic patient who's a child who probably needs a little bit of a boost. Remember, we should match the tempo of treatment with the tempo of the disease. So no matter how much we give, it should be given relatively slowly here. If this child were in hemorrhagic shock from trauma, what's the dose? 10 mL per kilo of packed red blood cells, repeated as needed. Now, if you gave that much to Sammy, who's stable, you would surely give him more than he needs, and the risk to benefit ratio is skewed, including volume overload. An old-time rule of thumb for children with symptomatic anemia, again, not acute hemorrhage, but just symptomatic anemia, is to take the current hemoglobin and use that number as your mLs per kilo of PRBCs to give. So, instead of the blanket answer of 10 mLs per kilo of PRBCs, that's more appropriate for an exsanguinating trauma patient, think hemoglobin per kg. Sammy's hemoglobin is 3.6. So, let's give him 4 mLs per kilo of PRBCs and see how he does. Now remember, we don't need to take him to a hemoglobin of 12 grams per deciliter right now from his current 3.6. We only need to bump him up a few points to make him feel much better and to get his physiologic compensatory mechanisms to chill. So, we're not hematologists. We will not have the definite answer to many of these questions. We should, however, be able to recognize some of the more common causes for a stable patient to have anemia. Non-specific symptoms in the right context will help. Just remember that decreased activity and decreased appetite, even respiratory symptoms, may be indicative of clinically important anemia. A pearl to hold on to. Anemia with a normal or high MCV is something bad until proven otherwise. Anemia with a low MCV often ends up okay. Regardless, everyone needs good follow-up and a plan. Remember the approach: onset, production, size, and morphology. Work through the steps and generate your differential diagnosis as much as you can. Since these are stable patients, you have the time to do that little extra brain work to help put them on a better course. And you'll make a difference in your patient's trajectory and your own professional development and satisfaction. Stay sanguine, my friend, and until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.